down here. Okay, we'll see if that works. All right, y'all ready to start newborn stuff? Yeah. What was that? We are starting on the best part now because you've already done all the labor and the delivery and all the issues with mom. Now we're going to get to the good part. The part that we all been doing all this for is to get a baby, right? So now we're going to talk about the baby. A lot of adaptations that the baby has to make to be born. I still get excited. I can still cry over babies being born because, you know, when you think about it, I mean, how miraculous is it that the baby can go from inside of mama with a placenta and a cord, and that's how they're being oxygenated and fed. And in a matter of minutes, they're outside of mom. Now they have to breathe air instead of fluid. And it works. I mean, most of the time it works. Babies cry, and you now have this independent human being. I just think it's amazing. And we sometimes get so caught up in some of the, you know, the medical part of it that we forget how incredible it is. And this little being has to adapt to so many things in order for all of this to work. And most of the time it does. There are certainly some things that can go wrong. But I hope you'll be as excited as me about learning about the baby because, you know, it really is what we've all been working towards. So let's kind of start thinking of things from the point of view of the baby too. You know how it's easy to see the mom contractions and the you know the fetal heart pattern and all of that. It's easy to see all of that, but the baby's sort of been hidden, and I want you to kind of think about a little bit from what the baby is experiencing. If you're the baby instead of you're the mother, and what is it like to be the baby going through this incredible day of delivery, and what all the things that have to change and what the baby has to go through. So that's where we're going to concentrate this morning, on what does the baby have to do to adapt to extrauterine life is what it's all about. Okay? So these are some of the forces that the baby has to deal with. I'll put this over here. Some of the things that have to go right or that can impact how the baby does. And most of them you have learned about, like you've learned about the antepartum experience, the mom's condition. Basically, did she get the right nutrition? Was she exposed to alcohol and drugs, or did she expose the baby to alcohol and drugs or cigarettes, anything like that, infections? And then the actual process of birth, what was going on. From the baby's point of view, was the labor difficult? Was the baby waiting a long time, like almost born, and then there was a delay? Was there analgesia or anesthesia on board? Because those things are going to greatly affect the baby, right? And think about this, you know, with, you know, if I took everybody in this room and gave them some kind of medication, the same, let's say, antihistamine or something like that, then everybody in here, most of you would react about the same, but there'd be a few people who could not handle that antihistamine. Some of you would be asleep within a few minutes. Some of you would, you know, maybe break out in hives, whatever. You would have some kind of reaction to it. And you know that about yourself, so you tell your doctor, you know, I don't do well with such and such a drug. That's not a good drug for me because I don't do well with those. And so you have a history. You have something to base all that on. But remember, babies are a clean slate. We don't have any idea if this is the baby that's going to react to that drug. We know what most babies do, but we don't know what all babies do. So sometimes when we have a bad outcome, it's something like that. It's just this particular baby doesn't do well with that drug. And it could be a drug the mother took, not a drug that the baby took. And it could be, you know, during the analgesia or anesthesia part. And then was there aspiration during the birth process? Because babies have lungs full of fluid, and that's fine when they're being fed by the placenta. But once the baby is born and now is breathing air, aspiration's a bad thing. You can't now put fluid in the lungs. You know, just the fluid that was already in the lungs is dealt with, but to keep on aspirating is a bad thing. And then coarse cord compression, if you're the baby, you're basically being strangled. Your oxygen supply is cut off. right, if the cord's around your neck. So that's a huge problem for how we end up adapting once the baby's born. And then physiologic abilities, this is just what is this baby made of. How mature is the baby, what are the condition of the lungs, and what do we need in the lungs in order to breathe well? What helps the lungs to stay open? Surfactant, there you go. So all of those things are going to affect how well this baby adapts to extrauterine life. Is there a disease process going on? And then this general state of health is something that's, when you think about adults, do y'all ever talk about hardiness, the hardiness factor with adults? I don't know if they call it that anymore. But you know how some adults are just tough? Yeah, like fortitude. And they just can handle a lot of things, and the same things can be thrown at somebody else, and it would be devastating, but this person just seems to withstand a lot of stuff. And we don't know if this baby is very hardy. Could be a very hardy baby and can handle a lot, and some babies are very fragile. So some of that is those unknown factors. And then the fourth thing is, where is this baby born? And are the people who are there to take care of the baby, are they equipped to take care of the baby? Do they have the equipment? Do they have the knowledge, the training, the people in place to do the best for this baby if there's a problem? We always try to transport mothers before the baby's born if we know there's going to be a problem. It's always better to transport them to the place where the baby's going to get the best treatment and mom's going to get best treatment. But we know that doesn't always happen because we don't always know when there's going to be a problem, for one thing. But even when we anticipate it, if the mother's too far into her labor, it's not safe to transport, right? So that's a big factor. The first thing we're going to talk about is how the lungs adapt. What happens with the baby's lungs in terms of what happens as soon as the baby is born and how do they adapt. What we know about the alveoli is they start to form at 24 weeks. So start thinking about premature babies that are born. Some babies are born at 24 weeks. So if they're born before 24 weeks, the youngest I've taken care of was 23 weeks. And that baby's eyes were fused. I've had several with the eyes fused, but this one was 23 weeks and less than a pound. So 24 weeks is right beyond that, and there are saving babies at 23 weeks, and I've heard of some younger than that, but the outcomes are terrible. And even 23 weeks, you hear a few miracle stories, but they're certainly not ideal, is it? 23 weeks, that's halfway through your pregnancy, so there's got to be some issues. But think about that, they don't even have alveoli until 24 weeks, so imagine how you're going to help them survive otherwise. You can still develop some of these things after birth, but you have to survive until then. So 28 to 32 weeks is when surfactant begins to be produced. That's a key number for us to remember, because before 28 weeks, we're going to need some artificial surfactant. And we're going to need some major help, because those lungs are going to collapse every time the baby has expiration. Remember, every time the baby exhales, the alveoli are going to stick to themselves if there's no surfactant. And then they're going to have to use a whole lot of force to open them back up every time. Babies can't do that over and over and over. So 28 to 32 weeks is our key. And you will hear, when you start paying attention to who you know that has a baby at a certain number of weeks, you'll start to relate this to survival and, were they on the ventilator, were they, how long were they in the hospital, that kind of thing. And it's all related to these kinds of things. And then at 35 weeks is when the peak is. So if you're going to have a premature baby, you don't have a choice about it, when do you want them to be born? At least 35 weeks, you're trying to get that mama to at least 35 weeks. And we'd like to get them even farther than that, right? Every single day matters. And so that's why they try to prolong the pregnancy as long as possible. Because nothing we can do outside of mama is as good as what we can do inside of mama, right? So we're going to try to keep them inside. Okay, that first breath is really incredible in that the lungs are, the alveoli are collapsed. So in order for that first breath to take place, we've got to establish pulmonary ventilation, which means oxygen in the lungs. And then the pulmonary circulation means the blood supply to the lungs has to increase to supply the lungs. The lungs have been getting a little bit of blood, with fetal circulation, but just enough to keep the tissue healthy, basically, not to oxygenate or anything. So now we've got to get pulmonary circulation and pulmonary ventilation going. All right, this little chart here is good for explaining several of the things that are in your book, but I'm trying to find my place on my notes. Hang on one second. I get ahead of myself. I get excited about this stuff. All right. So this chart just kind of breaks down some of the stuff that's in your book. It's already in the book the same way. I mean, a different way, but the same information. But these are the things that help to stimulate the baby to take their first breath. So down at the bottom, initiation of respirations. So we're going to go through kind of what each one of these does, okay? So chemically, what we want to do is on purpose cause a transitory asphyxia. We're asphyxiating the baby on purpose when we cut the cord, because the placenta was the source for oxygen, right? We're cutting that off, so we're on purpose causing asphyxia, but it's transient asphyxia. So we're going to, as soon as we cut the cord, there's a decrease in the O2, increase in the CO2, and a decrease in the pH. And then that's going to stimulate. That process stimulates aortic and carotid chemoreceptors. There are chemoreceptors waiting there that will only be activated if those things happen. And those chemoreceptors, once they're stimulated, they then stimulate the respiratory center in the medulla of the brain, and other nerve impulses in the spinal tract cause the contraction of the diaphragm, and the baby breathes. So if we don't cause asphyxia, none of that would work. We have to make those things happen initially. We can't prevent that. So always remember, if I say asphyxia, that's different than transient asphyxia that is normal. That is a normal part of the birth process. Okay, sensory is huge, because what happens with what the baby experiences here, think about if you're the baby, you're floating around inside of mama in a 98.6 degree environment probably, right? What temperature is the delivery room? Cold. We actually have a whole thermal section over here. It's such a big part of this process, the temperature change. But also, it's kind of every sound that the baby hears in utero is muffled and, more quiet. They don't have gravity to deal with. They're pretty much, by the time they get to be term, they're pretty squished up in there probably, but they still don't have much gravity to deal with. They've got some cushioning. The sounds that they hear, the smells, touches, and pain, they don't usually have much pain to deal with in utero, unless they have some kind of malformation or something. So when the baby's born, there are chemoreceptors that respond to all of those things too, all of those different proprioceptors and chemoreceptors. And that also is, the brain is waiting for those stimuli to help with the breathing. So same thing, respiratory center is stimulated, and that ends up resulting in respirations. And then the thermal, like I say, that's the biggie. The thermal is, the 98.6 to 72 maybe, or 74, whatever the temperature of the room is. If they're in the OR, it's probably colder than that, right? But that shock of temperature change is extreme, and we're worried about drying the baby off and keeping them warm and everything, but part of that process is what makes them take that first breath. Not only the fact that we're drying them off, but we're touching them, we're stimulating them, which is these chemoreceptors over here, the tactile, and then the thermal is that coldness, and now we're just drying them off and kind of stimulating in every kind of way. And they've never smelled anything except what they smell in mama, and now they smell different smells. All of those things come together to cause that same respiratory center to be stimulated. Mechanically, you've probably learned about this one already, about the chest compression from the birth. Have you already learned about that? How important that is? Not sure? Okay. So, when the baby is being kind of squeezed through the birth canal, if the baby's born vaginally, they're being squeezed through the birth canal, and when they emerge on the other side, they have to naturally take a deep breath, because it's like this sudden negative pressure that they get. So when they emerge on the other side, they gasp, and that's what causes the chest recoil. It says chest compression, chest recoil, stretch receptors, and an expulsion of lung fluid, and passive inspiration. That means they take that gasp because of the pressure, releasing the pressure of the birth. And that's part of what helps them absorb that fluid. They've got all that fluid in the lungs. It kind of pushes that fluid as they take that first breath. That kind of pushes that fluid into the alveoli and into the capillaries and on into the lymphatic system. So if they don't get that mechanical stimulation of birth, when would they not get that? C-section. So that baby's going to struggle a little bit more with that fluid in their lungs and stuff. So many times C-section babies don't do as well, or they don't clear that fluid as quickly at least. Okay, so after the first cry, the new inspired air is distributed throughout the alveoli, and then functional residual capacity is established. What's functional residual capacity? Say again? That's right, the amount of air that's left in the alveoli after the baby exhales. So you want to make sure that's established. If we don't have surfactant, what is that FHR going to be? FRC going to be? It's going to be 0 or close to it because it's going to keep on not holding on any air. It's going to collapse, okay? But we want to establish that functional residual capacity. Lungs expand more with each breath. It takes a lot of breath for the first one. And then each one after that is less pressure required for the baby to inflate their lungs, assuming they have surfactant. And then the fluid is absorbed or drawn into the capillaries surrounding the alveoli. So, you think about all that fluid that was in the baby's lungs when they were in utero. There's a few ounces in there if you measured it. When the baby takes their first breath, what happens to that fluid? Where does it go? Well, some of it's kind of pushed out when they got squeezed through the canal. So some of it they kind of pushed out, not coughed out, but pushed out with that first inspiration or expiration after that. And then the rest of it has to be dealt with by the baby's alveoli in their system. So they keep some in their lungs that they have to absorb. And that's done through the alveoli. And that's why when you listen to baby's chest right after delivery, you're going to hear a bunch of rattling around in there, some rails and some junk in there sometimes, because they're still trying to absorb that. And some of them do it beautifully. It's just like amazing how clear their lungs are. And others will sound really junky for a while, and they'll be trying to work with that. But the C-section babies are the ones you're going to typically see the more of that rattling, and you'll notice a big difference between the two usually. So within 2 hours, 80% of the fluid is absorbed normally, and then within 12 to 24 hours, you hope that it's all in. If they don't absorb it, they can become tachypnic and start to struggle with their saturations and that kind of thing. And there's something called transient tachypnea of the newborn, and we're going to study that in the last couple of chapters. But transient tachypnea of the newborn just means the baby has a bunch of fluid in there they can't quite get rid of. And the word transient means it's going to get better on its own. If it's not better on its own by 48 hours, we have to come up with a new diagnosis because it's no longer transient. Now it's probably respiratory distress syndrome or something like that. But if it's just transient tachypnea of the newborn, they usually require some oxygen and some support, so you can't feed the baby until the respirations go down. They can be like 110 respirations, 100 respirations a minute. They can really working hard to breathe. So they can be very sick babies, but it's all because of that fluid, and it's going to eventually get okay with a little bit of support. Oxygen support usually is all that's needed. Okay, so remember we said that if that baby doesn't get that squeeze, then that's one of the things that can cause us to not take that first breath very well. So that's one of the things. But other things would be underdeveloped lymphatics, meaning the baby can't absorb the fluid. They're maybe premature, so they don't have the system in place to help them get rid of that fluid. A small infant could be born vaginally and still not get a good squeeze, right? I'm talking about a very small baby is not going to get the normal squeeze. And a C-section, of course. Asphyxia, meaning not transient asphyxia, but the baby never did recover. Like something cord around the neck, something was going on meconium, something that caused them not to get the oxygen up and be able to deal with that. It was no longer transient ischemia. It was, or asphyxia. It was prolonged. So that's definitely going to interrupt that first breath. And then anesthesia of the mom, of course, can just kind of stun the baby, cause them some depression where they don't, those signals in the brain are not going to be received the same way. And aspiration. And aspiration of meconium would be the big thing, wouldn't it? We definitely don't want that. But it can just be aspiration of amniotic fluid, at the time of birth when it should have been more clear. There's too much amniotic fluid and they actually aspirated. Okay, we're gonna blow up some balloons, y'all. Now that I fed you a bunch of candy, we'll wake you up. We are literally gonna blow up some balloons. You're going, oh my God. Oh my God, what is she up to? So grab your balloon and pass it down. Put this one over here. Grab one quick and pass it back. I don't want to what? Ooh. Got a challenge. I should have gotten 3 bags. Everyone's going to be picky. Grab one and pass it back. Take it back for you. Oh, she got the pretty one. No, don't blow it up yet. Don't blow it up yet. Okay. Come on, Justin. Oh my goodness. I should have put it in a dark bag where you couldn't tell which one you're getting.
Oh Lord, why? This is wet.
Yeah, come on, you got for the challenge. I forget I'm being recorded. Oh my goodness, it's not going to record very well. All right, everybody have a balloon? Oh, not that way? How'd it get skipped over there? Some people do. All right, we got it? Okay. Everybody happy? Now, what other instructor lets you blow up balloons? I should have paused the audio, the video thing. I forget I'm being recorded. I'll probably have to redo it anyway. Hopefully not. If you're listening to this recording, everybody has a balloon. Well, I started it over there, didn't I?
No, you started with me.
How did I do that? Don't want to leave you out. All right, everybody has one now? Okay. Hang on. All right, so everybody blow up your balloon and then let the air back out, but do not let it go all over the room and spit on everybody, okay? Everybody blow up your balloon and then let the air back out. Let me get my camera. Oh no! I think that was his machine. Here, get a different one. Just throw that one away. All right, you can throw those away and get you another one. I didn't think you'd be able to blow that up. Yeah, you have no way of knowing what I'm going to ask you. Can't blow it up. I'm going to get somebody with the mouth on it. Okay. All right, so let's try to draw an analogy between this and the alveoli, okay? So we can try to learn something. Okay. Hope nobody had a latex allergy. I was supposed to ask you that. But hopefully you know that about yourself. Okay, so after you've let the air out of your balloon, what's that called? What's left in there? Functional residual capacity. There you go. Imagine if your balloon, you know how balloons have kind of that powdery stuff inside of them? Imagine if it didn't have that. When you let the air out, what would happen? It would stick to itself, right? So that's the analogy with the surfactant. So what if, even if they're wet though, babies' lungs are going to be wet even if they don't have surfactant. Let's think about if you filled your balloon up with water. If you did a water, but we're not going to do that. But if you filled it up with water and then you poured the water out, can you then picture more what it would be like? It would be stuck to itself. So what would happen if we just added like a drop of Dawn detergent to it? And then when you let the water out next time, it would be a little bit more, yeah. It kind of changes the surface tension on it. The surface tension and the functional residual capacity are affected. So that's the thing about, even though the babies are, still have wet lungs, they're still going to be wet alveoli, but if they don't have that soapiness, that silkiness that surfactant gives them, then they're going to stick and be hard to reopen. So that's the point of it. So that's our Dawn detergent. What increases the compliance in your balloon? So in other words, what if you blow it up the second time, is it easier to blow it up? Yeah, so of course it's easier the second time because you've stretched it and it's kind of just gotten some resistance, difference in the resistance amount. So same with baby's lungs. The first breath is very, very hard. It's something like 40 to 60 millimeters of water that it requires to open the lungs the very first time. And then after that, it only takes like 6 or 8 millimeters of pressure to open them, normally. So if the baby doesn't have surfactant, they're going to have to use that 40 to 60 over and over and over. So many times we'll have preemies that are born, and we're expecting this really sick baby to come in the nursery, and we were doing that. Who was in the nursery when we had that really small baby earlier in the semester? Okay, we were expecting anything. We don't know what we're going to get. How many weeks was that baby? 32 or something? So, we're expecting anything, but I said they might come in looking fine. And actually did look pretty good. We've had a couple, so I'm not sure which one you were there for. But they will come in and you're thinking they're not going to be able to keep on opening their lungs up like that. And that's what happens is at first they do have the energy. There's one in every crowd that's going to do that. Who was that? Was it you? You looked really guilty, Kaylin. Everybody says it wasn't me. Okay, so anyway, the baby will come out sometimes, these preemies, and they will be incredibly healthy looking, and they will breathe really well. Their saturations are good, but that won't last. We call that the honeymoon period because they don't have the structure, the muscle strength in their chest. They don't have the chest wall development or the lungs to keep on doing it. So they'll do it really well at first, and then they'll get tired, and they'll take less and less oxygen into their lungs, and they'll just start to wear out. And then they'll end up desaturating, and you have to intervene. Sometimes end up on the ventilator, sometimes just some extra oxygen, whatever it takes. But that's because that first breath is the hardest, and then after that it's supposed to be easy. But without surfactant, it's not going to be easy. The other thing that affects it is those of you who had a balloon that had like a skinny piece and then it got bigger, that's kind of like the baby's lungs. They have this tiny little trachea, and it's so tiny that it even collapses on itself sometimes. And then it leads to the alveoli, to the lungs and the alveoli. So if you've got that little tiny trachea, it's hard to push the air through that tiny little airway. That's why those little tiny skinny ones are impossible. They don't even have the alveoli at the end. There's no alveoli. So they're just impossible to blow up. They really need a machine for those. So that long, narrow airway, long, narrow part of your balloon, if you had one of those, is the reason it's harder to blow up than the ones that just come right open to a big old balloon. Some other things that interfere with how the baby breathes is the large heart. Their heart is much larger in relation to their body than an adult. Takes up a lot of space in there, so that kind of compromises the lung space. And then the high diaphragm, they have a much higher diaphragm than an adult as well. That's why that big old belly, they normally have a big belly, expected to have. And between the high diaphragm and the large abdomen and the large heart, their lung space is different. Also, their rib cage is more rigid. So their ribs are more horizontal than ours are, and they just don't move as easily. They're more rigid. That's why you see them doing abdominal breathing when we're measuring, we're looking at their respirations. We're looking at their abdomen to see how they're breathing because their chest wall doesn't move as much. Their intercostal muscles are weak or not well developed. Even if they're full term, we're talking about even full term, they have relatively weak muscles in their chest. And I already said the narrow airway. Okay, so we'll move on to the next slide then. Wasn't that fun? Yeah. Y'all are like, whatever. Okay. All right, so let's talk about the newborn, the normal respirations for babies. You all know by now that they're 30 to 60 because you've done the nursery. But we definitely saw some outside of those limits sometimes, didn't we? But mostly above that, it's okay to have up to maybe 80 and in the 80s right after birth. And why would that be? What are they dealing with? That extra fluid. They're trying to get that fluid out of their lungs. So they're going to be a little bit tachypnic sometimes after birth. So they say for the first couple of hours, that's okay. After that, especially if it's affecting their saturation, we're always monitoring their saturation anyway, so if their saturations are good and they're breathing fast, we're just watching them for the first couple of hours. But if a baby keeps on breathing fast after those first couple of hours, you're getting concerned because the baby's compensating for something. There's a reason they have to be breathing that fast, and that's going to show up in some other way eventually. Also, if they're crying and all those things, you can expect that the respirations will be different. They are normally irregular, right? Hopefully you all learned that in the nursery, that you don't have just normal breathing in babies, just this great, perfect little rate, right? It's going to be like Cheyne-Stokes in an adult. It's the apnea, and then it's the breathe, stop, wait, breathe, squirm, hiccup, breathe. It's whatever you see is what you count, right? So as long as we don't have 20 seconds, see how it says 20 seconds there, as long as those pauses are less than 20 seconds, that's not apnea. Okay? Always shallow. And of course, they're diaphragmatic breathers, abdominal breathers. They're also obligatory nose breathers. So babies prefer to breathe through their noses. And that's why they're perfectly miserable if their nose is stopped up. If they've got that nasal stuffiness, then they're pretty miserable. Of course, that makes sense because they have to be sucking a lot. So if they're sucking a mama or a bottle, they need their nose to breathe through. So they can breathe through their mouth, but they prefer to breathe through their noses. Okay, so then when do we know the baby's in distress? These are the things that we look for. We're going to look for cyanosis for sure, color change. But we know babies are born looking kind of funky with their color anyway. We don't know what to expect sometimes, do we? Let me switch my notes. So blue is okay for, the first few seconds or maybe first 15, 20 seconds or whatever, but after that we should be starting to get pinker. Retractions. When we talk about retractions, you need to know the 4 different kinds of retractions. You have substernal. That's just in the middle of the sternum. That one, y'all didn't get to see a lot of this. Some of you got to see some. And then you have suprasternal. That means above the sternum. That's up in your neck. You know how above the sternum you start to see that sucking in. That's suprasternal. Intercostal, which is between the ribs. That's the one we saw the most this semester, I guess. Intercostal, between the ribs. And then subcostal is below the ribs, where you can see it kind of sucking in their abdomen. Then we have nasal flaring. Nasal flaring means they're kind of air hungry, and that's one of the first signs of respiratory distress actually that we see, or the mild distress you might only see that sign. Sometimes that's the only thing you see is nasal flaring. And then grunting is expiratory grunting, and it's an effort for the baby to fill their alveoli. It means they're closing their glottis and they're pushing to open up their alveoli. So they're going like that. And they sound like they're whiny, but they're usually, and we did get a couple of babies like that this semester. Some of you remember that? Anybody? That we saw that baby which one was the one that was whining, like really whiny sounding? Was that the preemie? What was that? No. Anyway, so it doesn't sound like grunting, it sounds like whining. It's like, So if you didn't know what you're listening for, but what that is they're closing their glottis and pushing, and that's trying to open up their alveoli. Grunting is never a good sign. We don't ever want to hear grunting, and when they're doing that, it is always something that we need to look at. And then rales, that would be that fluid in their lungs. So those are our signs of respiratory distress. Let me see if I left anything off here. I think that was good. Okay, so that was the respiratory system adaptation, basically. And then we go to the cardiovascular system. And cardiovascular is huge. We know that, y'all learned fetal circulation, right? You all know how to trace the blood through the heart for the fetus, correct? If you don't, you need to review that. And I put a video out there for you, one of those cons videos. He's just great at explaining things. And I gave you one for fetal and one for post-birth circulation and the changes that occur from his point of view. So I think he can probably explain it better than I can. But just be sure and review that. I know that you've already covered it. This is just a couple of different slides to help you to see the color changes, to help you to follow the blood as it goes through. And what happens with these, this would be fetal circulation here, because we still have the foramen valley open and all that. And then this one is a comparison of prenatal and postnatal, which I think is kind of nice side by side and see what sort of changes take place. And we're going to talk about some of the specifics. I'm not going to go through this in detail now because I think this is really one of those things. I think when you sit down by yourself and watch the video or sit down and read it, you've got to kind of take it in, because it just otherwise just goes. I've learned over the years that students are like, I don't remember you going over that, because it's something you just sort of have to get in your head. But you need to follow the path before birth and after birth, and then realize what happens to all the different structures that make a change. Let me see what parts I had here that I wanted to make sure I pointed out. Well, I gave you a slide on it, actually. This slide here will help you to kind of know the kinds of things that I want you to understand change at the time of birth. So definitely the aortic pressure goes up and the venous pressure goes down. In other words, when they cut the cord, there's now, it used to be free for the baby's blood to just keep on flowing right through the placenta. You know, there was a place for it to go, and now there's no place for it to go. It stops. So that pressure starts building up, okay? Whereas before the lungs were just full of fluid, so the blood really couldn't go in there. Now the lungs are opened up, and blood can flow through the through those arteries and veins of the lungs. So those pressure changes is what I want you to understand. Aortic pressure increase, venous pressure decrease, systemic pressure increases, and pulmonary pressure decreases. And then you know that the closure of the foramen ovale happens, but it's not permanent, is it? Not always going to just slam shut at birth and then be stay shut, because it's not a sealed shut, it's just a flap, basically, because remember the foramen ovale is between the two atria, right? And before birth, there was more pressure on which side of the heart? The right side. There was more going on the right side, right? More pressure over there. The left side wasn't getting a lot of activity, okay? So once the left atrium fills up, it now sort of slams the door. So let me go back to that other picture. See which one. So this might be this one. So before, this one wasn't really doing much. This one was full of blood. So once this opens up, and now we got blood going up into the lungs, coming back, and filling up this left atrium, this side now has more pressure, more blood, and more pressure. And so it slams that door shut. It's like a little flap. But it doesn't seal shut. It's just closed for now. And some babies, the pressures will be such that it never really opens up again in a way that we can hear it. But sometimes it does. There's like, the pressure changes, and the flap kind of goes back and forth for a while. So I need you to know a couple of numbers in terms of when those kinds of things happen. So the foramen ovale, I think I had put for y'all to memorize. The book keeps on changing it, but this edition says 2 hours usually. But it can last up to 30 months, is what this book says. They keep on changing it drastically, so we'll go with what this book says. So up to 30 months for permanent closure, in other words, sealing shut. That's a huge difference between 2 hours and 30 months. So that's why we need a cardiologist to figure out when we have a persistent murmur, we need a cardiologist to take a look at that baby and decide whether we should be worried or not. Because sometimes we just know there's a murmur. We don't know if we should be worried about it or not sometimes. Okay. So back to this one. So closure of the ductus arteriosus. So you know the ductus arteriosus, there's a couple of different things that cause it to close. Do y'all know what those are? You already learned all that? What's the trigger for the ductus arteriosus to close? Anybody know? What is it? I heard it. Oxygen. Oxygen, there's a chemoreceptor in the ductus that causes it to constrict if it's exposed to oxygen. Okay, also prostaglandins, remember that? Prostaglandins is what keeps it from, kind of blocks the oxygen that is exposed, they are exposed to in utero. And prostaglandin keeps it from closing. Even though, because some oxygen does get to it, right, in utero. And we don't want it to close up in utero. So the prostaglandin keeps that little bit of oxygen from closing it up. So prostaglandins is essential to keeping it open. And that's supplied by the placenta, and the placenta's gone now. So therefore there's no prostaglandins to block the oxygen effect. So now when we get a lot of oxygen, that thing just wants to shrivel up. This is one of the things we're going to come back to when we get to preemies. They don't get good oxygen because of their alveoli, their surfactant issues and all of that. So theirs tends to stay open. They get patent ductus arteriosus is what it's called. and they often have to have surgery for that because theirs just won't close altogether. So they keep on mixing oxygenated and unoxygenated blood together, and it causes some real problems for them. But normally in the full-term baby, that's going to close because of increased oxygen and a loss of prostaglandins. I remember taking care of a baby that we wanted it to stay open after birth because of a heart defect, that mixed blood was better than nothing. So we actually had to give artificial prostaglandins to the baby to keep it open. And that was the first time that I had actually known that was possible. But that might help you to remember. Okay. Okay, so 18 hours is what this book is saying is the closure of the ductus arteriosus, and permanent closure at 2 to 3 weeks. Okay. It makes me realize they don't really know when these things close, because every book you pick up tells you not just a little bit of difference, but huge amounts of difference in their wide range of disagreement on those numbers. But we'll use what this book uses. Okay, so then the ductus venosus, remember that's the one that was supplying what? That's the liver, yeah. So that was the ductus that was kind of cutting the liver off. The liver didn't need a whole lot of oxygenation. Needed just a basic blood supply, and once that is closed, I think that's more of a mechanical reason that it ends up closing. But anyway, it closes at 2 months. So without the ductus, the blood is forced to go on through the liver and keep it oxygenated. So it closes at 2 months. You really don't see a lot of symptoms based on that one like you do with the other, a lot of disease processes that are associated with these two not doing what they should do, but not that one so much. Okay, so these are the cardiac things that I want you to know. The 110 to 160 is your normal heart rate, but we know that when the baby's asleep, it could be down 100 or less sometimes, less than 100 sometimes. We're not comfortable with that. I mean, you're never okay with it unless you've learned that that's the baby's normal. And it tends to be the really bigger babies, more mature and bigger babies that have lower heart rates. You're going to learn that later that your preemie has a high rate of 220 as their normal. It's still, so try to count to 220 in a minute on a preemie's heart rate. It's hard enough to count to 110 or whatever. Most of y'all said 140s and 150s and that kind of thing. But 220 is your normal high rate on a preemie. So it fluctuates, the cardiac number actual fluctuates during whatever activities. I hope that you got to kind of notice that when you're taking, because you have to listen for a whole minute, and in that minute you probably heard it go up and down. And that just means that the rate is going up and down. It's not irregular unless the rhythm is what's changing. So faster and slower is the rate changing. But when we say it's sometimes irregular, it's okay for it to be irregular slightly, but when you start to hear all these clicks in there and like the bigimines and the trigimines and things like that, then that's not normal. That kind of irregular is not normal. So it should fluctuate. The rate fluctuates, but the rhythm should be somewhat normal. The normal blood pressure, I want you to memorize is 70/45. It's not in your book that way. They give you a mean pressure to go by. But let's do a 70/45. And I'll tell you the crazy way that I remember that, and it makes no sense to anybody else, but maybe it'll help somebody. You just have to trick your brain sometimes with some of these things you memorize. But I just do half of 70 is 35, and then I add 10. Don't tell me why that works in my brain, but it does. So half of 70 is 35, but that's too low, so we're going to add 10 to the bottom number. Okay? If that helps you at all. Okay. 70/45. Okay. Now murmurs. Let's talk about murmurs, because we can hear murmurs all the time on babies, and we know that 90% of those are transient and okay. The baby's going to be fine. It's just going to be a matter of time. But there are some babies that it can be, especially if it's like a significant murmur, a really loud murmur, I can't say murmur, or a persistent one that continues throughout another day or two. Babies get ready to go home and you're still hearing a murmur, but you still have great saturations. Of course, we're looking at the whole picture, right? We would certainly be worried about a baby that had a low saturation, and especially if they had a murmur and they had all the other things. But if your baby has a murmur and no other symptoms, when do you worry about them is the thing. And I don't know the answer. I know the doctors know the answer, but they kind of judge it by how loud it is and where it is exactly, which valve it is that they're hearing it on. But basically, if there's still a murmur at discharge, they're going to either follow up with the pediatrician. Sometimes they won't wait 2 weeks to do that. Sometimes they'll have them come back sooner. But often they will just wait till the 2-week visit and then decide whether to do a cardiac consult with a cardiologist. So like I say, I can just tell you there's a murmur. I can't tell you how bad it is or what it means. I've asked Dr. Kilgore about this I don't know how many times, and he's like, he can't tell either sometimes. He has some things that can indicate, but basically when to be concerned and when not. This last part is important because the right ventricle is larger and thicker than the left, because the right side of the heart, remember, was the only side that was functioning in utero, right? So the right side got a lot more workout when it was used. So the left side is pretty, not atrophied, but pretty much not gotten a good workout. But this is why babies tend to do better when they have right-sided heart failure, or not failure, right-sided heart defects than they do with left. If they have left-sided defects, they tend to not do as well. I know you learned some of those in pediatrics, right? Did y'all have to learn some of the heart defects? Okay. So that's why we really worry about the ones on the left. And it's kind of the opposite of adults, because adults, you want that left ventricle. You need that left ventricle. That's our lifeline, isn't it? So you have an adult who has a left ventricle problem, you got an oxygenation problem, you got a big problem, either arrhythmias or something. But it's the opposite with babies in general. Okay, why don't we take a break and then we'll start back up with the rest of it. Okay. Well, this clock is wrong, but if it was right, let's do 10 after, okay? Thank you. Here we go. Okay, so we're going to pick back up on physiologic anemia of infancy is the next thing when we're talking about at least in the order for this chapter. And some of I think I'm on the right page, aren't I? Yeah, that's the next slide you have, right? Yeah. Okay, so let's talk about the red blood cells and how they're different in newborns, in that they have more than they need. They are born with too many red blood cells, basically, but they are immature red blood cells, so they don't have a long lifespan. They just live 2 or 3 months, and therefore all of these immature but plentiful red blood cells are going to start dying off at the same time at around 2 to 3 months of age. And that's when, I don't know if any of you can relate this to when you're raising your children and all, that sometimes around 2 or 3 months is when they want to add iron to their diet. We used to give formula that was without iron in the beginning, and then we added the iron later. Why would you not want to give too much iron in the beginning? What's the side effect of iron? Constipation. So you got babies that get constipated, so sometimes they would not give them the formula with the extra iron in it until they needed it later. So like 2 or 3 months they would add that one. But now I'm seeing that they're not they're starting them off with the same one. The one with iron is what they're starting them off with. I'm not sure what the rationale is and how that's changed, but anyway, that might help you to remember that that's physiologically makes sense. So their hematocrit is high to begin with. Normally it's high, so if they have any issues, then it's going to be even higher. Let me find my glasses. They're not on my head or on my nose here. Yes. Mm-hmm. Yeah. So they could get more. Did you say the mother wanted it? So she requested it?
Yeah, and they did it.
Yep. That's an excellent question. We want to talk about the debate about that. There's pros and cons about whether delayed cord clamping is good or bad, or what are some of the decision making you do. I think it might be the next slide even. So let's wait and talk about it then. But that's a good question because it definitely is related to this. One of the reasons the hematocrit is elevated is that babies are sort of dehydrated. They tend to not, their fluid intake tends to be low in the beginning, so they get dehydrated anyway. So that's one of the reasons that we have a high hematocrit. But so we know that it's going to be high, and it's normally high. So and it's going to be even higher if they have like bruising. The red blood cells, plentiful red blood cells. But you're going to have even more of those if you have a lot of bruising or any kind of trauma. Asphyxia causes increased production of red blood cells. So there's a lot of things that can go wrong in the baby that will make this even more so. But even if they're normal newborns with none of those problems, they have more than they need. Okay? But they are immature. And that's going to kind of come up as we start to talk about some of the abnormal things that happen later. The last two chapters of this unit are all the abnormal things, but they tie into all of this. So, okay, the placental transfusion is what you're talking about, Shantanique, is delayed cord clamping that's the other name for it. So placental transfusion just means that you literally either delayed the clamping and allowed the blood from the placenta to go into the baby, or you held the placenta up higher than the baby on purpose to let the baby get that blood. So a lot of things to think about when you're doing this. I understand one of the new physicians at the hospital is doing this now. Did y'all witness that? But it's just like a minute or so, I would think, right? Or maybe just a minute. Pardon me? Do you think it was longer than a minute? Really? Maybe a minute to 3 minutes, maybe, or something. Okay. Yeah, it would depend on a lot of things. There's a lot of philosophy about it. Some people are really believing that it's a good thing now, but it's not always a good thing. But anyway, when you do this, when you hold the placenta up higher than the baby, normally the baby has 200 or 300 cc's. That's all they have in their whole body. And if you hold that placenta up, they can get an additional 100. And 100 added to only 2 or 3, you can see that's a lot. So that could be a good thing if mama's bleeding and hemorrhaging, you're assuming baby's going to be suffering from some anemia also. Or if you have some real indication for it, then that could be something that we've always done on purpose if we knew that there was we knew baby needed blood. Because, it's a perfect match, right? And they're certainly not going to be having a reaction to the blood, so it's a good match and everything, but we can't measure how much we're giving the baby. We don't know how much we're giving them. So it's you're hoping that it'll work out. So the hematocrit would then increase to 65 instead of 48. 48's already high, but it would increase up to 65 possibly. So I said potential treatment for expected hypovolemia. But this is where your book goes into some of the controversy now, and we've been hearing about it because some physicians are wanting to do it. But basically think about this. All of those red blood cells, the more red blood cells the baby has, the more he has to conjugate through his liver. His liver has to conjugate all of that. And what are we going to run into problems with the liver? What do babies have related to the liver? Jaundice. He has to metabolize all of those extra red blood cells. So babies who do have delayed clamping, the studies are showing more jaundice, more treatment for jaundice, and the kind of jaundice that actually requires phototherapy. So that's one of the disadvantages that you can think of for sure. But then the advantages, some of the studies are showing that it causes better perfusion of the organs, especially in preemies. The preemies, it looks like the research is a little more solid on preemies as far as what the advantages of are, because the other studies are a little bit controversial. They're back and forth. Some will show advantages and some won't. Let me see if I can find it in the book. What page is that, y'all? 476. I see it. Let's see if I can remember. Yeah, this one says 30 to 60 seconds is the definition for delayed umbilical cord clamping. I've not seen anybody actually do it. I haven't been in delivery where they did it, but I was wondering how long this physician has been doing it. Let's see what else it says. So the newborns who got the delayed clamping also had higher iron levels, so they had later suffered less iron deficiency anemia. But the con was the phototherapy for jaundice. And had something to do with blood pressures. There were some in preemies. The solid research had to do with their bowel and liver and all of that perfusion. So they did seem to do better with that. Necrotizing enterocolitis is one of the things you're going to learn about. It's like an infection of the bowel, and they had less of those. Preemies did. The other thing was I was trying to think of. The other con was if the baby needed resuscitation, you're delaying the resuscitation because you're still waiting to cut the cord. So that could be a problem, I guess. Anyway, interesting debate. We'll see what happens with that. A lot of things that we've been doing forever, we think are the best way to do things, and then somebody's adventurous enough to try something new, and then it ends up being standard of care. So we'll see what happens with that. I don't know. It's been something that, mostly it would happen with babies who were born outside the hospital, and EMS brought them in, and they sort of accidentally got the transfusion because they didn't cut the cord. Maybe they were born in the bathroom at home, and nobody knew what to do, so they just left the placenta attached. Those are usually the babies that we would see over the years. So I don't know what we're going to be seeing now in terms of actual treatment in the hospital, whether it'll be something that we see on purpose. Okay, so now we're going to get into temperature regulation. Hopefully you know from working in the nursery how important this is, right? I hope you got that idea at least, because definitely all of you dealt at least a little bit with this issue. So everything with babies, there's almost a policy related to every temperature you can think of on a baby. But there's a reason for that. Babies are homeothermic. Human beings are homeothermic in that they try to strive for a certain temperature. We want to be 98.6 all the time, so we have to work at it. If we're in a cold temperature, our body has to do all kinds of things to keep us at that 98.6. If we're in a hot temperature, our body has to do stuff to keep us cooled down to 98.6 so that we don't become whatever our environment is. So that's what homeothermic means. So if the baby's too hot or too cold, his metabolism increases. And when the metabolism increases in a baby, that means he's using up his oxygen resources and his glycogen, his glucose, which is, his oxygen first, his glucose, which is in the form of glycogen in the liver, and then his carbohydrates and his, that's pretty much, his fat. He starts using up his fat. So he's got to use up things to help him stay warm or to keep him warmer, either cooler if he's in a real hot environment like that baby in the car. They will use up all of their different mechanisms that they can to try to regulate their temperature. So they're going to use their oxygen and the glycogen stores first, and then they're going to start using up their fat supply. okay? It's always going to be a very bad thing if babies have used these things up and they're still not at the right temperature. Then we're going to get to acidosis and death. That's really what happens if he exhausts every other resource he has. What we call the perfect temperature for a baby is their neutral thermal environment or neutral thermal zone. We're going to use the NTE or neutral thermal environment. Some books will call it this one, but it really blew my mind when they started trying to call it that because I can't change my old way. But they've gone back to NTE, thank goodness. But what it means is this baby's neutral thermal environment is the perfect temperature for this particular baby to not use up his oxygen and his glucose and his fat to stay warm. He's got the perfect environment to just be comfortable and to not use up all of his calories and all that. So a preemie is the example of this. A term newborn should not have a problem with maintaining their own temperature after the first couple of hours. Now at first they do need a little help, but once they're neurologically and physiologically more stable, they should be able to maintain their own temperature with, with clothing on and that kind of thing in a normal room temperature. But preemies are not able to for a lot of different reasons. So that's why we need an isolette. This is an isolette. Some of you didn't get to see one, I guess, this semester because we just didn't use very many. We didn't get preemies this semester. They're not doing back transports from Richland like they were. So that's very sad for me because I really enjoy taking care of the preemies. But that's what you would see. It's basically this isolette is like this baby's own room. And it's like his own little bubble of temperature he needs. Okay, so you turn that up to whatever temperature he needs. So that's his little house. So that baby, there's like a table that you go to that you decide what temperature to put this baby on to begin with, to start at. And if the baby's, next time you take the baby's temperature is too hot, then you turn it down some. Too cold, you turn it up some until you get it to the right temperature. And then as they mature, you should be able to turn it down a little bit every day until now it's at the same temperature as the room is. Eventually it's the same temperature as everybody else is at, and then he can come out of that isolette. He's graduated to a regular bassinet. Does that make sense to y'all? Okay, so they need extra help in the beginning. So his neutral thermal environment is basically his best environment for the least oxygen consumption and glucose utilization or calories based on the age and the weight of the baby. So that's the table that we go to, the chart, to decide what to set it on to begin with. And then we adjust it from there. These are some of the things that affect the baby's neutral thermal environment. How much sub-Q fat does he have? Because even if we have a baby that's not premature, if he's SGA, what's SGA mean? Yeah, so if he's small, even if he's mature, he could be 40 weeks, he doesn't have much fat on him. So his fat's not going to be there to keep him warm. So decreased sub-Q fat, thin epidermis. Even a full-term baby has a thin epidermis compared to an adult, where you can sort of see their veins under their skin. So they don't have, when you have a thin epidermis, you have blood vessels that you can see, so that means they're close to the surface of the skin. So the temperature of the room affects that blood that's circulating, and then that blood goes back down to the organs in this body and affects the core temperature. Okay, y'all understand how that works, right? Because you've learned about vasodilation and vasoconstriction and how our body tries to vasoconstrict if we're cold, so that our blood vessels don't get exposed to the temperature of the room so much. Yes? Okay. All right. So that's basically the idea here. The baby doesn't have any sub-Q fat between his vessels and the environment, just that thin little layer of skin. So he's going to easily be affected by the room temperature. And then the other thing is his body posture. He wants to be in a fetal position. A fetal position protects your surface area. You're kind of covering up part of your surface area, right? So that decreases some of the effects of these things. But if a baby can't curl up and be in a fetal position, then he loses that ability to conserve his heat. And the babies who can't curl up like that are Preemies don't have the muscular structure to do it. They don't have the flexion tone yet. They can only do this. They're like the spread eagle. Everything is just out there for the environment to affect. They can't protect themselves. And the other is a sick baby, a real sick baby that's real floppy and real flaccid and no muscle tone. They're not going to be able to protect themselves. They're just lying there. So those are the babies we worry about. The posture is not going to help them with their temperature regulation. Okay. These are some of the ways that heat loss occurs to the environment. I don't have like a slide that tells you all of them, but I'm going to give you some examples of some nursing, either some environmental things or some nursing things that are related to each one of these. So convection, we know, is heat loss because of air currents. Convection has to do with air currents. So there's currents around the baby. It's taking heat away from the baby. So that would be like the air conditioner or a fan, right? But also simple things like walking by. Some of you have seen me like when I'm after I bathe the baby, I just cover his head and everything to walk back to the crib, and it just seems like why would you cover up the baby like that? Because how can he breathe? But he can breathe for those few seconds, because when you walk with a baby, you're creating an air current, and he's already got damp skin, so you definitely don't want to do that. So that's about convection. See some other examples. Just transporting a baby, you just always want to cover them. Raising the side of the radiant warmer, those walls that are around him keeps those currents from getting to the baby. And in an isolette, it would be the portholes that we use the portholes to keep from getting air drafts to the baby. Using hats and blankets. Okay, so radiation is the other one. So radiation is a cooler, solid surface that is not in direct contact with the baby, draws heat away from his body. So it's not in direct contact, but it's cooler than the baby. We used to always have to worry about things like if you put a formula bottle, you wouldn't worry about this with a full-term baby so much, but with preemies, if you had a formula bottle, you get ready to feed the baby and you set it beside the baby, it's colder than the baby and it's going to draw heat away from the baby. And that doesn't seem like a big deal, but if you only weigh 3 pounds or 2 pounds, then that is a big deal. Setting an IV bag, for instance, near a baby, that would draw heat. So anything that's not actually touching, but pulling heat away. Also would be like a window. If you put babies near in the NICU at NUSC, we had a wall that was exposed to the outside of the building, and the rest weren't. And we never put our sick babies near that wall, because we wanted our sick babies not to be affected by that colder wall. That wall is just colder. Even if there's no window, it's still colder. So you would, that has to do with radiant heat loss. Okay. What else? What other examples? I think that's basically it. The only ones that really we need. I keep thinking I got another slide, but they're all on the same slide. Okay, evaporation. That one's pretty much self-explanatory, but you're talking about insensible water loss for the baby. So through perspiration or pulmonary fluids, things like that. So the nursing interventions we would want to put in place, one is we dry the baby after delivery, right? Because they got amniotic fluid all over them. Removing wet blankets as soon as we can when we're bathing the baby. When we're bathing the baby, we try to keep each area of the body covered when we're not bathing that area. Put a cap on them in the delivery room. Changing wet diapers. Things like that. Conduction. This one is the same, except that this time the colder object does come in contact with the baby. I think this one's a little bit easier for everybody to understand, because we think about this with everybody that we take care of. We don't want cold hands when we touch people. Cold stethoscope. A cold bed. For babies, we keep the beds pre-warmed in the nursery because of that. So you're always trying to warm things up that you're going to touch the baby with. They could lose heat to the scale on the baby scale when we're just weighing them. When we discharge a baby, we think about car seats, because if it's real cold outside and we put the baby in a cold car seat, we want somebody to go warm that car up first, so the seats aren't real cold. Or if it's hot outside, we've got the same problem with transferring heat to the baby, don't we? So those are the basic things about heat loss. We're always thinking this way when we're taking care of fragile babies. And how do babies produce heat? This is important concept for them because they don't do it the same way that we do. There's something called non-shivering thermogenesis. It's sort of a defense mechanism against heat loss, or it helps them to produce heat. Babies don't shiver. If they shiver, it's a very late sign of cold stress for them if they do shiver. So when we're cold, we shiver involuntarily to warm up our muscles. That's our defense mechanism. But babies don't have that mechanism in place yet. So they have something called non-shivering thermogenesis. But before they even get to that, let me back up. Before they even get to that, they're going to become restless. You see a baby that's starting to get cold, they will try to warm themselves up by becoming restless and to assume a fetal position if they're able to. And just becoming restless generates heat. So that's more, it's not exactly shivering, but it is kind of an involuntary movement of muscles that they try. If you're very observant, you can see this in babies, but it's not something you're easily going to pick up on. So they basically rely on this non-shivering thermogenesis. And this has to do with the central nervous system and this special adipose tissue that is brown fat. Brown adipose tissue or brown fat. And brown fat is really special fat. God thought of everything. So it's a fat that babies have only in the most important parts that protect the main organs in their body. In your book, you've got that picture of that convection and radiation, heat loss, and all that. And it has in that same picture, it shows you little shading areas, page 478. You see the little shaded brown areas? That's where the baby's brown fat is. All the most important organs are protected by the brown fat. And this brown fat has rich supply of blood vessels, nerves, and cells, and it's located in all the most critical areas. And when the blood circulates through this brown fat, it warms the blood. And then the blood continues to flow through the rest of the body. Okay? So isn't that genius? I tell you, God thought of everything. So they start developing this special brown fat around 26 to 30 weeks. So which babies probably need it the most? Preemies. So if they're born before 26 weeks, they don't get it. So that's the problem. But it does keep on developing until the baby's after birth, the baby for several weeks after they're born. So it's a real good defense mechanism for circulating the blood through a very rich supply of blood vessels and nerves and cells. And then circulating it onto these deep organs that need to stay warm. And put down here again that shivering is a rare in newborns, but it's a late sign of cold stress if they do shiver. And cold stress is, possibly going to lead to acidosis and death, so that's why we worry about it so much. Okay, so if the baby's not able to use his brown fat, there's some circumstances where he can't. So these are the things that prevent him from metabolizing his brown fat. One is hypoxia. So in hypoxia, they tend not to use it as well. Hypoglycemia, acidosis, and some drugs will prevent it. Demerol being the classic one. And that's not on your slide, I don't think, is it? It's not all of it on here. Demerol's on here. Okay, so Demerol, that we just learned years ago, somehow mamas who got Demerol, their babies were colder. They just didn't tend to do so well. So we don't use Demerol very much on mamas anymore. But down here we talk about hypothermia can cause prolonged and exaggerated effects of some drugs. So hypothermia sort of blocks the effects of this this special fat. Any questions about any of that with temperature regulation? The other part would be hyperthermia. I don't think there's a slide on hypothermia apparently, but hypothermia usually is our fault. Usually we cause hyperthermia on babies. It's some kind of equipment failure or we're over dressing the baby. Usually it's not the baby usually. Now sometimes they can have fever, but not often. Most babies, when they're sick or have infection, they have a low temperature. If they have a high temperature, it's sometimes because the mother has a fever. And the mother has a type of infection that caused her some fever, and baby will sometimes have fever right away. But most of the time they have a low temperature, and that's the one we start thinking of septic workup when we get low temperatures that we can't correct. So otherwise, increased temperatures are usually caused by our warmer. That's the classic one, the warmer malfunctions. I've seen a number of warmers malfunction, and they won't even alarm or anything. They'll be seeming like they're working fine. So it's another good example of why we nurse our baby, not our machines, right? But the alarms can be off, or sometimes they just don't alarm. That's what I see more often. But the first thing I think about when I see a baby's heart rate start going up for no reason is he overheated, because the first thing is his heart rate's going to go up for no particular reason. He's not crying, nothing's going on, heart rate's just starting to race. So that's your first sign. And he's going to get tachypnea as well, but he definitely is going to start increasing his heart rate. He's going to become flaccid, muscle tone. When we get flaccid, he'll just look exhausted, like hot and exhausted. And heart's racing. Extended body posture, because he's trying to lose his extra heat. See if I left anything out. So the same things happen with overheating that happened with the underheating, and that the baby's got to use up his oxygen, use up his glucose, his glycogen, and his fat to use energy to keep him cool, to try to cool off. He's trying to compensate. All right. Now this section is going to get into something totally different. Let's see what time it is. Okay. Let me see where I want to go with this. I think we'll just start a little bit of it, and then we'll skip some of it. So what I need to do tomorrow for sure, or not tomorrow, but next week, next lesson, is do jaundice. And jaundice is too big to get into unless you can stay in it. So we're going to cover jaundice next week, not this week. That's the big piece that I want to save. But part of the hepatic adaptation to extrauterine life, we can cover a couple of slides for this one, and then we'll skip the jaundice part. So some of the hepatic stuff. This is how does the liver adapt to extrauterine life is basically what we're talking about. We talked about the lungs and the cardiovascular system. So as far as the liver goes, these are some of the issues that we think about. Low vitamin K levels. You know, babies naturally have low vitamin K. You already knew that, didn't you? Okay. And that's why we give that one, because of the prolonged coagulation, prothrombin time. Normal intestinal flora is needed. And what do babies have instead? They have a sterile gut, okay? So a sterile gut does not lend itself to production of vitamin K. So that's why we have this problem. So make sure you understand that mechanism, that the pathophysiology with that, or the physiology with that. So the sterile gut, until the baby gets some formula or breast milk, they're not going to have anything but a sterile gut. So formula is what changes that equation. And it says normal flora develops by the 5th day. So in the meantime, if the baby had any kind of incident, could be something with their cord, it could be a circumcision or any kind of procedure, they could have major bleeding problems in those first few days because they can't clot their own blood, basically. So we give this vitamin K prophylactically. That's a state law, at least here, and I think probably every state in our country, it's a state law to give the vitamin K. Okay, so now we're going to move on to GI adaptation, and this is how does the baby handle food and just using his tummy. Let me find my notes. Got to switch notes. 2, 3. 4. Well, I don't know where it is. I don't think I had one exactly the same way with that one. That's why. Okay, I remember. Okay, so so the GI system has got to try to handle the formula right away, or either the breast milk, and the capacity is about 2 ounces. Babies don't usually take that much, but that's pretty much the max capacity that you have in the tummy. They don't digest fats very well because they lack lipase, and that's why the formula is, formulated exactly that way if they're not breastfeeding. And they don't digest starches very well. So that's why when Grandma tells you to give the baby some rice cereal so he'll sleep, yes, he will sleep, probably. It will work. Anybody agree? Anybody give that? Because Grandma just said you really need to give that. It will work, but the problem, what they think it happens if you give starches before you should and they don't have the enzyme, is that they think it might set them up for allergies in the future, is one of the disadvantages. But basically, they don't have what it takes to digest it. So it's not going to be well used by the body. So I don't know why it works so well, but it does work. When babies won't sleep, sometimes you add a little bit of starch to the starch, which in the form of usually rice cereal. It does seem to help, doesn't it? What's that? Yeah, so they have more in their stomach. So, but it's interesting because it actually is not using it. Anyway, so pancreatic enzyme levels increase by 2 to 3 months, so that's when they start to be able to do that. That's why usually you add your cereals at 4 months. About 4 months is when most pediatricians are going to say, you can go ahead and start feeding the baby a little something. Anybody pediatrician recommending sooner than that? Yeah? What age? Really? Oh, reflux. Okay. For reflux, that's a little different because it thickens it. They're basically thickening it. Yeah. So I guess in some cases it's worth the trade-off, but definitely we do see it in that case. The cardiac sphincter is weak, so baby spits up easily. That's a normal full-term baby has a weak sphincter. So even if they're not preemies, they're going to have that spitting up thing sometimes. And some babies are just born as spitters, and some are just not. Anybody agree? Got a baby that spits and a baby that doesn't? Anybody? I mean, one time they're just, you think they're never going to stop spitting. So the intervention for that spitting, because of the cardiac sphincter, is burp them often, don't overfeed them, and then put them on the right side after you feed them. But we can't really tell parents to put them on the right side unless you're holding them or watching them very closely now, because we don't want them to end up turning to their tummy. Normally lose weight the first week of, or really even the first 2 weeks possibly after birth. They're going to normally lose weight up to 10%. Okay? So we usually tell them at the 2-week visit your baby should be back up to their birth weight. Not going to have gained weight past their birth weight. They're going to lose first and go back. So they require 120 calories per kg per day, and you're going to know that very well by the time I'm finished with you, but we're not going to go into that today. But you're going to learn how to calculate that so that if you have a neighbor that says, my baby's eating this much, I'm worried about him, you think he's getting enough, to gain weight. Because, once you're an RN, everybody thinks you know everything. And they're going to all call you, and they're going to say, well, my baby's doing this and this, and, what should I do? And you're going to be able to pull out this little calculation and tell them, how much is the baby eating? And then you can do a little calculation and go, well, it sounds like you're not eating enough or eating too much or whatever. So I want you to be able to do that. Okay, when you get to newborn stools, hopefully you all got to see some meconium at least, right? Excuse me. Meconium is very unique. It's a stool that you'd be very alarmed if you saw on an adult. But it's thick and tarry and sticky. It's very sticky. Can be black or green. It has no smell, though. That's the nice thing about it. There's no odor. Otherwise, nobody would want to work in the nursery if we had a room full of stinky babies. But the only babies who have any smell to them are usually the ones that have been there for several weeks, and they have, or at least a week or so, and they're starting to get a regular stools now, and then their feedings start to affect the smell of their stool. But in the beginning, we don't have stinky babies. By the time they start smelling bad, they go home usually. So that's the nice thing. Then you have a transitional stool, which it means there's still some meconium mixed in there, but now it's getting some formula or breast milk mixed in, 2 to 3 days. And then the cow's milk stool is what you're going to see for formula-fed babies by the 3rd or 4th day. Starts to look pale yellow, formed and pasty, and odorous. Breast milk stools, again, the 3rd or 4th day, but they look totally different. And only people who breastfed will understand that they have kind of a sweet odor. People who breastfed nod your heads, because it's not like a good sweet necessarily, not a nice sweet, but it's not that unpleasant either. It's not as bad as like goat milk. It's terrible. Goat milk makes them bad, huh? So, and some of those Nutramigens and those special formulas are really bad for that. But breast milk stools have kind of a sweet odor to them, and there's all kinds of levels of normal in terms of how many a baby has. It's incredible. To me, I think about babies and how many that's usually the first question somebody's going to ask you is, he seems like he's constipated. He hasn't had a stool today. He's constipated. And once they go home, that's a big concern. Especially if they're fussy, they want to relate it to that. But most physicians will say if the baby's got passing stool and it's soft after they pass it, then they're not constipated. And it doesn't matter how often, as long as they're having one, usually once a day, but some babies go 2 or 3 days. Even breastfed babies sometimes. Most breastfed babies have more, but not always, or not for long anyway. Once they're more established, they don't always. But anyway, babies are just very dramatic about their bowel movements. They just like to make all kinds of noises and sounds and faces and squirm and carry on, and you think they're just dying. And then they pass this very soft stool. And that's what you go by. Not how many faces they make while they're passing it, because I don't know what it is about it, but they can really be dramatic about their bowel movements. So basically it's what the stool looks like once it's passed. At least in most cases. There's certainly exceptions. Okay, urinary adaptation. Their filtration rate is low at birth. So that's what I was talking about when I said babies don't always handle medications very well. You don't know which ones can do what. So it depends on the baby. But even normal full-term babies have a low filtration rate. You know how we say the people we worry about when we talk about fluids and medications are the very young and the very old, right? Because when you get older, your filtration rate changes too. So in little babies, we are very concerned about fluids because of that. So they have a decreased ability to excrete large amounts of fluids at a time, and to reabsorb sodium and hydrogen, and to concentrate their urine. So in other words, large amounts or small amounts of fluids are a problem for babies. They can't adapt very well to it. So fluid overload or dehydration would be a problem. And then this also certainly affects the excretion of drugs. We want them to void in the first 24 to 48 hours. Some physicians will get concerned after 24, others will give them a little bit more time. Because often what happens is they did void at the delivery and nobody could tell that they voided at delivery. So we don't want to overreact, but you're going to start assessing the baby, see if they seem like they're in pain for one thing, but also they get very restless, and abdomen starts to get more distended, or the bladder area, and you would get concerned. So possible causes of no voiding are urethral stenosis, absent kidneys, or absent ureters. You just don't know what's inside of this baby. When I worked at MUSC 100 years ago, one of the most common things we saw were problems with the GU tract, stuff which usually affected the genitals and all of that too. But there are all kinds of weird things that can happen on the inside of babies with their bladder and their ureters and all of that. We saw tons of that compared to other things that just seem like one of the most common things. I don't know what it is about that stage of development, but many of them can be fixed, certainly, and many can be pretty catastrophic. Uric acid crystals show up as brick dust spots in the diaper. It'll look just like brick dust, like you took a brick and you just shaved some of it off of it and sprinkled in the baby's diaper. That's what it looks like. And it's very alarming to parents because it has kind of a reddish look to it, like they were bleeding maybe. So you just need to explain that that's initially what you see because there's uric acid crystals in the bladder at the time of delivery. So sometimes it takes a couple of days for all that to get washed through, and you will see those brick dust spots in their diaper sometimes. And then pseudomenstruation is what you'll see in the little girls. So that's actually frank blood that you would see in their diaper, and very alarming to parents. So it's very important to tell parents of girls that this might happen, because they will rush them to the emergency room. If they open up the diaper and see blood, you would not understand why that would be happening. But that's like a little mini period, and it's just based on the withdrawal from the mother and the hormone influence of the mother. I think we're going to stop there, actually, because this gets into a little bit different type of topic, and I think that y'all need to have a little meeting, don't you? So I think we're going to actually stop here. We'll pick up here next week. If you get a chance to look at jaundice before you come, it might help you with that lecture, because that one gets a little deep.